Okay, so thank you for tuning in for the Anatomy, Biomechanics, and Kinesiology review of the cervical spine podcast. We're going to be discussing the anatomy of both the AA joint as well as the OA joint. So the occiput articulating with the atlas, as well as the atlas articulating with the axis, C0 to C1 and C1 to C2, as well as the mid and lower cervical spine. We'll get into a little bit of the soft tissue, and we're going to at least introduce biomechanics for this. Recognize Chapter 25 is the required reading. You should be looking at pages 1256 to 1269. Additionally, there's a PDF on biomechanics of the C-spine posted in Blackboard under the lab section or unit for cervical spine, so please take a look at that. Again, we'll be unpacking that further in class, probably not on Monday, but more so on Wednesday as we get into some of the manual therapy. So let's go ahead and get started. When we look at the cervical spine, the upper cervical spine, otherwise known as the craniovertebral region, is approximately 25% the height of the cervical spine as a whole. And when we look at the craniovertebral region, we recognize that that is primarily composed of C1 and C2 as well as the occiput. The lower cervical spine is recognized as C3 through C7, with your typical cervical vertebra being C3 through C6. The upper cervical spine is different due to the orientation of not only the atlas, but also the axis because of the dens and the lack of a spinous process on C1, as well as the vertebral promens on C7. It becomes more of a thoracic vertebra at that point. The posture throughout the cervical spine is primarily cervical lordosis, which is maintained by the discs. They are thicker anteriorly and thinner posteriorly, which is what allows for more of a lordotic or extended position of the spine in the cervical area. The nucleus as well is positioned more anterior than what we see in the thoracic or even the lumbar spine. Even though the lumbar spine does have a lordosis, cervical spine is slightly more so. Of note as well, on this screen, you can see kind of denoted with the red and green boxes the upper and lower cervical spine. However, also recognize we do have other structures here as well. So for example, we have the uncus or the uncinate process on the right-hand side of your screen. And that is the small kind of lipping areas that exist within the cervical spine that not only help in terms of maintaining integrity of the disc, but also serve as a kind of bony block to end range cervical side bend or lateral flexion. When we look at the anatomy of the lower C-spine, specifically we see that the body is about as half as wide anterior to posterior as it is medial lateral. It's much wider in that medial lateral direction. There is that posterolateral lip that we just discussed, the uncinate process or the uncus, and this is a frequent site of spurring. And so when we say spurring, we mean kind of osteophyte formation, which would lead then to not only a loss of range of motion, most notably in lateral flexion, but could also begin to create a little bit of an issue within the transverse foramen, which is where we would find the cervical artery and even into the intervertebral foramen. So we just need to be mindful of that. The vertebral arch or the neural arch is short, it's horizontal, it's often bifid as well, and it leads out to the spinous process. The transverse process then is where we find the transverse foramen, which is where we see the vertebral artery passing through. The articular surfaces we've already talked about in class are angled at a 45-degree orientation one to another from the horizontal, and this is why more rotation occurs in the cervical spine than anywhere else within the spine. It's due to this orientation. Keep in mind the thoracic spine is going to change to a 60-degree orientation, and by the time we get to the lumbar spine it's going to be 90 degrees. The 45-degree angle is really advantageous then for allowing not only rotation but also a coupling motion of side bending, which we'll talk about momentarily. The major ligaments we've already talked about in class. Those are the anterior longitudinal and the posterior longitudinal ligaments, which run the entire length of the vertebral body, both anterior and posterior, throughout the spine, and help to reinforce not only the disc itself, but also serve as a check to both flexion and extension. We've already also talked about that C7, or the vertebral prominence, is considered atypical. The spinous process is the longest, which contributes to it being more prominent, as well as being part of the transitional CT junction. And so it looks almost more like a thoracic vertebra than a cervical one. At that CT junction, we move from great mobility to more limited motion. The facet joints move from 45 degrees to approximately 63 degrees to their orientation, again replicating more of the thoracic spine. Because of this transition from an area of more mobility that we see in the cervical spine to an area of less mobility that we see in the thoracic spine, the CT junction is a common area of restriction, a common area of hypomobility, and a common area that we target manual therapy towards, both in terms of mobilization as well as manipulation. For movement of the lower C spine, recognize that we have all of our cardinal planes here: flexion, extension, lateral flexion, and rotation. Rotation, lateral flexion, and extension are greatest in the C spine of all of the different kind of spinal segments. And when you think of lateral flexion, think of it as being synonymous with side bend. Those two terms are used interchangeably. And also recognize that lateral flexion is coupled with rotation. Okay, now why does this occur? We'll talk a little bit more about this in biomechanics and kind of as we jump into that section of the spine. But when you side bend, there is that 45-degree orientation of the facet joint, or the articular pillar. And so as you side bend, the vertebra, or the inferior facet on the vertebra above, will slide posterior and inferior on the superior facet of the vertebra below. Okay, I'll say that again. The inferior facet of the vertebra above will slide posterior and inferior with ipsilateral lateral flexion on the vertebra below's superior facet. Okay, and we'll talk about this a little bit more in class, right? But it's because of this that rotation will occur with slight ipsilateral lateral flexion, and why lateral flexion occurs with ipsilateral rotation. Okay, it's a coupled motion. We don't see true or pure movements of just lateral flexion or just rotation. There's always going to be some carryover. Now we can bias our movements more towards rotation or more towards lateral flexion, that's for sure. But just recognize to have full lateral flexion, you need rotation. To have full rotation, you need lateral flexion. You can't have one without the other. Okay. The vertebral body will rotate toward the concavity. So keep that in mind, which is why we see that ipsilateral rotation. And then the spinous process rotates opposite, right? So the body is going to go ipsilateral, but the spinous process goes contralateral. So for example, if we're looking at C3 rotating on C4, the spinous process of C3 is going to move contralateral to the rotation, meaning if you rotate to the right, the spinous process will move to the left, whereas the body will move to the right, stays ipsilateral. Okay. Because again of this coupled motion, flexion and extension are the only pure movements that we see within the cervical spine. Okay, and maximum flexion extension really occurs between C4-5 and C5-6, which is why these are common levels for cervical disc pathology, right? With the most common level being C5 and C6. Okay, we've already talked about a capsular pattern. It's questionable at best once we get to the spine. Cyriax has proposed that the capsular pattern is lateral flexion and rotation being equally limited, with extension being less than flexion. Right, and this makes sense. If we're going to lose one more than the other, we're going to lose extension. One, we have less of it in terms of total range of motion, but two, because the cervical spine is already in slight lordosis, there's less mobility there to lose if there is a capsular restriction. So now let's transition and look at the upper cervical spine. First, we'll look at C1, which is the atlas. It has no body. It does have a vertebral arch, but no spinous process. There is a small posterior tubercle, and then there are these lateral masses. which serve as the articular surfaces for the occipital condyle. And so those lateral masses are concave, whereas the occipital condyles are more convex. The transverse processes of C1 are quite long. You notice this in lab, that you had to be quite a bit lateral, and they're actually palpable just under the ear, anterior to the sternocleidomastoid and the mastoid process. These transverse processes also contain the transverse foramen, which is where we see the passage of the vertebral artery. And so this is one of the reasons why it's important to palpate the transverse process for C1 in order to maintain or ensure that the maintaining of integrity is there, specifically following trauma. If we move to C2, which is the upper spine as well. This is known as the axis, and so the articulation between C1 and C2 is called the AA joint, the atlantoaxial joint, whereas the articulation between the occiput and the atlas is called the OA joint, the oxoatlantic joint. Here the body is made up of the dens, which is this process that rises superiorly from the body. We see the odontoid process there as well. With this, our vertebral arch is going to have a significant spinous process, and often is bifid. And then we have very small transverse processes. The facets, here we have several. Okay, we have a superior articular facet and an inferior articular facet, which is where we see C1 and C3 articulate. When we look at this a little bit further, we can see how exactly the different structures are articulating. For example, the axis tends to have more of a convex shape to the superior facets. It doesn't quite look like that in this picture off to the left with the kind of netter's anatomy, but it tends to be more convex in nature, articulating with more of a concave inferior facet of the atlas. And then as we move down to the inferior facet, which is where we see the articulation with C3, it follows kind of the normal process. However, we also then have the anterior and the posterior articular facets of the dens. And both of these are convex, right? And so why this matters is this is where we get most of the rotation in the cervical spine. It's between the C1 and C2 vertebra. And it's this dens kind of spinning against the C1 vertebra. So we'll jump back for just a second so you can see that. If you look off to that right-hand side of the screen, you can see the articular facet for the dens, and that is going to be more concave. And then that is where the rotation would occur. Okay. So then let's keep moving here. When we talk about C1 and C2, we have to talk about two important ligaments, one being the alar ligament, one being the transverse ligaments. There's other ligaments as well, which the majority of them pass from the occiput to C2. C1 acts kind of as a washer then between them, and really there's no disc in the upper C spine, right? So here we see the tectorial membrane, which kind of serves almost like a ligament of sorts, okay? We also see the posterior longitudinal as well as the anterior longitudinal, but specifically the occiput to C2 is going to contain the alar ligaments. And these are known as check ligaments. They limit rotation of the skull on the C2 vertebra. Okay, and so they pass then to the dens. Okay, you also have the apical ligament of the dens as well, but those alar ligaments pass from the occiput to the dens of C2. Side bending of the head will cause that rotation because of the coupled motion there with C2, and so we can start to we can start to assess the intactness with that, and we'll talk about that kind of as we move through the lab portion. The other one is the transverse ligament, and the transverse ligament is part of the cruciform ligament, which helps to support the dens and hold it against that anterior arch and the anterior facet and articulation of C1. This should always be assessed in a cervical exam if there's any history of trauma. Reason being is if this transverse ligament of the atlas is compromised or destroyed, that dens can actually move more posteriorly and can compromise the spinal cord and can lead to cervical symptoms consistent with myelopathy and other more traumatic issues. Additionally, these ligaments can be eroded in rheumatoid arthritis as well as Down syndrome, and so we need to be mindful in those conditions as well if our patients are reporting symptoms that we're assessing the integrity of the transverse ligament, even though trauma is likely not present. The intervertebral discs really first appear between C2 and C3 because of the nature of C1 and C2. There's not a disc that exists between them. The nucleus propulsus will be 25% of the disc, and the height to vertebral body height ratio is 2:5, which is the greatest ratio in the cervical spine. It is reinforced mainly anteriorly. We already kind of discussed that. And nearly almost all of your patients over the age of 40 years of age will have evidence of degenerative disc disease. There's not much there to begin with, and so any loss within the space between the discs can have a fairly profound impact. By 4th and 5th decades, the nucleus propulsus usually dries out or desiccates, and this also contributes to signs and symptoms associated with degenerative disc disease. For the craniovertebral muscles, this is important because these are often areas of pathology, specifically after more traumatic events such as a whiplash or a fall or something along those lines. We have the rectus capitis anterior as well as lateralis. We have the posterior suboccipital muscles, rectus capitis posterior major and minor, and then obliquus capitis inferior and superior. You can see most of those on this image from Dutton. On the right-hand side of your screen, all the way at the top, we see rectus capitis posterior minor and major. We can also, as we come down, see the obliquus capitis superior as well as inferior, helping to pass essentially from the medial portion to more lateral portion, helping with rotation. Additionally, we can see the occipitalis muscles. Hopefully with this image you can see the orientation of the occipitalis as they relate to the greater occipital nerve and the occipital artery, which are common issues when dealing with cervical headaches or cervicogenic headaches. You can also recognize the orientation of splenius capitis, as well as start to see a little bit of sternocleidomastoid as well. Superficial cervical muscles moving out include the upper trapezius, sternocleidomastoid, the levator scapula, rhomboid, scalenes, and the platysma as we move more anterior. For the trapezius, obviously this is the big broad muscle on the back or posterior aspect of the cervical spine. Sternocleidomastoid is going to be coming off of the mastoid process and extending back onto the occiput, then inserting distally or further down essentially on the clavicle. Levator scapula is a rather important muscle on the posterior aspect that will insert on that medial and anterior angle of the scapula. And then as we get into rhomboids, still further kind of parascapular muscles inserting on the lower cervical spine. Scalenes are very important in terms of issues associated with thoracic outlet and brachial plexopathies. And then finally, the platysma in the anterior portion of the cervical spine. Finally, we get into the deep cervical muscles. Here we see semispinalis capitis, we see splenius capitis and splenius cervicis, as well as the cervical erector spinae. Moving more anterior, we get into the deep neck flexors. Deep neck flexors have kind of become a hot topic in recent years as they have had some convincing evidence showing poor activation and also increased fatigability following trauma and motor vehicle accident. And so oftentimes these are targets of rehabilitation and plan of care due to kind of their involvement following some form of trauma or mechanism of injury. So these include the longus coli and longus capitis. You can see those on the right-hand side of your screen coming from those anterior bodies and extending down, as well as rectus capitis anterior and posterior, not as easily visualized on this graphic. The neurovasculature of the cervical spine is rather important. We need to be mindful of those and be screening these structures when we're dealing with patients who are complaining of symptoms associated with the cervical spine. More nerve roots than actual vertebral levels, keeping in mind that C8 is the level between C7 and T1. Also, we have the greater occipital nerve along with the OA and AA joints is often implicated in cervicogenic headaches. And so we see that when we're looking at the suboccipital region of the upper cervical spine. The upper three nerves are really associated with neck and head pain. Lower cervical nerves we think of as being more shoulder, anterior chest, upper limb, and scapula. There was a nice referred pain or at least referred symptoms graphic from Magee that I posted in the lecture from Friday. I would encourage you to kind of peek at that, showing the different root levels and where that referral tends to go. Again, the upper three nerves more to the head and neck, even wrapping around to the lateral and even anterior portion of the head, whereas lower cervical nerves more shoulder, anterior chest, some upper limb, and scapula. Cervical nerves as well we need to be mindful of are the trigeminal and facial nerves. And then when it comes to the blood supply or arteries, we have several. The most important that we need to be mindful of, which is the vertebral artery. Not to say that the other arteries are not important, but because the vertebral artery is passing within that transverse foramen, when we do mobilization strategies or manipulation strategies, we need to ensure that we're maintaining safe practices. We're ruling out any pathologies, we're screening, and we're also maintaining our ability to watch our patient's response to ensure no intolerance to the intervention that we're providing is being experienced. The carotid artery is also available, which serves as a secondary blood supply further up the chain and will contribute to the circle of Willis. We have the suprascapular and brachial artery, as well as the axillary artery. Again, all associated in this region of cervical spine moving down into the glenohumeral joint. We're going to briefly touch on biomechanics, though we will discuss this in more specifics within class. This is really meant to be an introduction and just start getting some of the gears turning. Again, I would encourage you to look at the PDF covering some of the biomechanics that's posted in the Blackboard section for cervical spine as well. When we're looking at biomechanics, we first have to recognize that 50% of the motion occurs at the upper cervical spine. Both the OA and the AA joint motion occur relatively independently, and then once we get below C2, motion is a combination of motion, and so there's this coupling that occurs. Why does this matter? Well, in our assessment, we need to be screening both upper cervical spine as well as lower cervical spine. Part of how we can know, or at least kind of clue into whether or not there's a restriction there, is to look at gross movement. So you noticed in class when we went through lab, we first looked at gross movement actively, then we assessed gross movement passively, and then we began to start funneling, moving to intersegmental, and really looking at the upper cervical nod, upper cervical extension, and then looking at rotation as well. This is important because this is part of the funnel. We first want to know if there is a restriction, and then we want to find out where that restriction may be. Is it more upper cervical, lower cervical, and then if we can, even narrow it down to individual levels. When we get below C2, though, we see this combination of motion, otherwise known as coupling. And coupling is this idea that side bending and rotation are going to occur together. Okay? Now, there is an article posted in Blackboard with a little more information on this if you want to dive in deeper, as well as information within, again, the PDF on biomechanics. Within that article, it talks about coupled spinal motion is the rotation or translation of a vertebral body about or along one axis that is consistently associated with the main rotation or translation about another axis. Right, and that's probably the best definition of coupling motion or coupled motion that we have. In the PDF, if you kind of peek at that, you'll note at the bottom of page 3, we start talking about the rhythm of cervical movements, both flexion from neutral and extension, as well as rotation from neutral and side bending from neutral. From there, we then get into coupled motion. And there's a helpful example here, that being that side bending to the left also have rotation of the vertebral body to the left, but then the spinous process is going to move contralateral to the right. This is what we discussed earlier. Okay, this rotation occurs when the facet joints are actually contacting each other, and that sliding produces rotation of the spine and the vertebral body. Okay, with this motion, okay, we can then start to discuss patterns of restriction known as closing restrictions and opening restrictions. And for now, I'm going to leave it there. We'll discuss that more so in class with some demonstrations. But just begin to think about how this combination of lateral flexion and rotation would start to influence things. Again, because we have to look at upper and lower cervical spine, we need to understand kind of what's going on at those joints. With the upper cervical spine, we see the OA and the AA. Here, flexion extension is a combined motion as well, meaning you get some of both. The total motion is 15 to 20 degrees, with flexion contributing about 5, extension about 10 degrees. Very minimal rotation occurs. This is more arthrokinematic than anything, 0 to 8 degrees. Very little side bending occurs, 9 degrees bilaterally. Okay. However, they occur opposite each other. So if you side bend to the right, you rotate to the left. So it's opposite what we see elsewhere in the cervical spine, essentially below C2. Okay. At the AA joint, the major motion is rotation. This is where we get up to 45 degrees of rotation on each side. The studies do vary. Dutton, I believe, says approximately 45 degrees. And then there's that graph that we'll look at again in this podcast, but we also looked at the other day when we were looking at the functional anatomy of the spine and kind of where flexion, extension, side bend, rotation occur. The first 25 degrees is going to occur at the AA articulations. Flexion extension is going to have a total of about 10 degrees, side bending 5 degrees. So again, very, very small. With flexion, we see side bending and rotation to the same side. With extension, we see side bending and rotation existing oppositely. And this is due to the orientation of the joints, that being more convex occiput and more convex axis, articulating with more concave facets of the atlas. Okay. Moving then into the lower cervical spine, again, the zygoapophyseal joints are going to move inferior and medially with extension, or superiorly and laterally with flexion. Okay, and again, they're going to be coupled such that extension of the ipsilateral joint and flexion of the contralateral joint are going to occur with rotation and side bending. Flexion and extension, it's approximately 50 to 80 degrees total arc. We'll discuss that flexion has somewhere between 50 and 60 degrees. Extension has closer to 45 to 50 degrees. That's a little more than what we see here with 50 to 80, but this is more clinically what we anticipate to see. Most folks are not going to have that much flexion and extension, though many of your classmates will. Okay. Rotation and side bending to the same side, whether in neutral flexion or extension. This is kind of discussing what would be existent from neutral. So this is what we're talking about in the PDF PowerPoint, in the PDF Biomechanics. So take a peek there, and again, we'll discuss this further in class. So total cervical range of motion then, again, sources vary. We just kind of discussed this. Flexion and extension 50 and 60 degrees, side bending 45, rotation approximately 80 up to 90. Very few people are going to have 45 degrees of side bending. Very few people are going to have 60 degrees of extension. Reason being is they're already in extension. If you look at them, they're already in a degree of lordosis. Okay. So just be mindful of that and kind of screen that. Again, this is that graph that we looked at with the functional anatomy of the cervical spine. Again, look at C1, C2, upwards to 45 degrees of rotation is occurring at that joint, as well as C0 to 1 and C1 to 2, flexion extension. This is where we get the upper cervical nod. But again, very, very minimal rotation is occurring and virtually no lateral flexion. Very, very small. Okay. C1, C2, again, half rotation of the cervical spine occurs here. Okay, so that's where we're going to pause for now in our discussion of biomechanics. Again, take a peek at the anatomy. Other anatomy that we're not going to discuss in depth here, but you should be familiar with, is what root levels are associated with certain dermatomal patterns. We covered that already in the upper extremity. We went through both peripheral neural testing as well as dermatomal testing. That correlates to the anatomy and understanding potential radiculopathy and involvement of that spinal nerve root level. You should also be aware of what muscles are being innervated by those root levels, right? And so again, we've already talked about that with regards to our upper quarter screen and our upper quarter, shoulder, elbow, forearm, wrist, and hand discussion. All of that now has to carry forward to our discussion of the cervical spine. So that's really why we kind of set the course up as we do, such that we cover all that before we get to the cervical spine. So if those are still areas that are gray or need further clarification or need further review, please do so. Please peek at that. And then, as I said, we'll be discussing the biomechanics further in class.